Υγεία Hospital.
Thank you very much. I'm honored for the invitation from the organizing committee. Of course, I do not pretend to know the future of neuromodulation. What I can offer you is a sensation of things to come and a glimpse of the future. So let's have a look at the past first. For now, for the time being, the Medtronic InterStim is the gold standard in sacral neuromodulation. It is FDA approved since 1997 and had thousands of patients that undergo the procedure. The indications include non-obstructive urinary retention, bladder overactivity with or without incontinence, and fecal incontinence. Nevertheless, there are different severe limitations in the procedure. First of one is that the lead placement is the single most important step of the procedure, and it is quite difficult despite the standardization of the technique and the introduction of the curved stylet. It is a two-stage procedure. It is quite costly. The battery needs to be replaced. The mean battery life is of 4.4 years. And it's not MRI compatible. It is MRI compatible only for brain scans, even though there had been studies that show that you can perform an abdominal MRI without any serious risks. It operates under continuous mode, which may or may not be necessary, and that also causes nerve fatigue and battery depletion. And last but not least, the reluctance of patients to undergo such a procedure, despite that their symptoms may be quite bothersome. So, does technology offer us any answers to these limitations? The Axonics system has been recently introduced in the European market. It is available in some European countries. It features a rechargeable battery that is much smaller than the InterStim battery and can be recharged by the patient by wearing a special belt that every 1 to 2 weeks for an hour or two, and has a battery lifespan of 15 years, in theory at least. You can do a full body MRI, even though that's conditional with a time limit and limitations in the amount of energy you can undergo. It is a single stage procedure and has a 71 response rate according to the RelaxoAb study. As I said, it's available in some European countries. It is not yet FDA approved, although there is a study to gain FDA approval is underway. And of course, all these improvements will not be left unanswered by the Medtronics. Medtronics already has the SureScan technology that allows for full MRI scans, and the plans in the future are to have two battery models for neuromodulation. The InterStim will be non-rechargeable with SureScan technology, and smaller rechargeable battery with SureScan technology as well. But the question is, could we get rid of wires and batteries altogether? Because that could answer some of the problems of neuromodulation. And yes, there has been a recent feasibility study that quite experimental in 5 patients, where only a very small lead was introduced, and the whole thing was powered externally by wireless power transfer. And in this study, they had an 80% visual response rate. That means they show the bellows contraction and the curling of the toe. And of course, in the future, we will need to miniaturize the external powering unit. Perhaps we could get some answers from the advances in tibial neuromodulation when it comes to this. And we'll need clinical trials as well. As I said before, lead placement is the most important step, because the better the placement needs, the more programming options we have, the lower the voltage and the longer the battery life will be. An idea would be to have 6 contacts instead of 4, and there has been some recent experiments in pigs. Of course, we know from other neuromodulation techniques that we can have a wide variety of electrodes, and we'll see perhaps some of them in the future. Another idea about improving lead placement would be to have first a 3D reconstruction of the pelvis, make some virtual puncture lines, and then create a 3D printed model to improve the introduction of the lead. And sacral neuromodulation has the main indication it has been used for, and sometimes we show that some quite beneficial side effects. And also sometimes it has been used off-label for a variety of conditions. And the question is whether there will be some other indications in the future. What we know so far is that female sexual function is closely related to the voiding dysfunction. And studies that in women with voiding dysfunction that underwent sacral neuromodulation showed improvement in sexual function regarding arousal, satisfaction, and pain. Of course, in all the studies, the female sexual function was a secondary endpoint, and we will need further studies with sexual function as a primary point. And also, from past studies, we have seen that neuromodulation has a beneficial effect in erectile dysfunction. Logically, this is mainly in the neurogenic population and specifically in the spinal cord injuries subpopulation. And randomized clinical trials underway for this specific population. Another topic where sacral neuromodulation has been used off-label is pain. And in all studies, well, visual analog scores were used to evaluate the effect of sacral neuromodulation, so that there is a very good beneficial effect, and mainly in patients that had pain for causes other than interstitial cystitis. Okay, patients with interstitial cystitis perform a little worse when it comes to pain, but sacral neuromodulation in the patients with interstitial cystitis has a beneficial effect in the other aspects of interstitial cystitis, like voiding dysfunction. Another crucial question is whether we can use sacral neuromodulations for patients with detrusor underactivity. Now, sacral neuromodulation is approved for non-obstructive urinary retention, but this is a very heterogeneous group, mainly with women with Fowler syndrome or other neurogenic problems, and that doesn't necessarily include the detrusor underactivity. So in this study, there has been an attempt to evaluate in which patients with detrusor underactivity we can use sacral neuromodulation. And the answer is yes, we can use it, but not in patients with very severe detrusor underactivity. Patients with the bladder contractility index of 35, residual with more than 300 mLs, very small voiding volumes with 50 mLs do not go well with sacral neuromodulation. The success rate in this group was only of 20%. What they used was the Maastricht-Hanover nomogram that uses bladder outlet obstruction index and maximum Watts index to discriminate the patients, and those below the 25th percentile were patients with detrusor underactivity, and whereas the group between the 10th and the 25th percentile had a success rate of 86%, the patients below the 10th percentile only have a very small success rate. Another group of patients that is very difficult to treat are the patients that have overactivity in the filling phase, but have underactivity in the voiding phase. That's something we see quite often in the elderly population and in the neurogenic population as well. And they're very difficult to treat because if you give medication or Botox for the overactivity, there's a very high chance of urinary retention. So the question is whether we could use sacral neuromodulation in this group of patients. And in this study with a small group of 20 patients, they had a 70% success rate. So that's an idea for future uses as well. It's very effective in the neurogenic population, despite the problems with MRI compatibility and patients that will need multiple future MRIs. And it's also understandable that it will perform worse with patients that have a progressive disease rather than patients that have a stable disease. We'll see whether the improvements in technologies will give us some answers to these problems. It's not approved for a pediatric population by FDA for less than 16 years, although it has been used. It is highly successful, but you have to understand that it has very high revision rates compared to the adult population, mainly because of the somatic growth that causes lead misplacement. And there's also the need for multiple surgeries for changing the battery over the lifetime. And we also don't know how many of these patients will need MRI scans in the future. And once again, advances in technology perhaps will give us some answers here. And so far I have been talking about sacral neuromodulation, but that's not the only kind of neuromodulation that has been investigated or used in urology. We all know tibial neuromodulation. These are the devices that are currently in market, the concentric surgeon PC and the Medtronic Neuro. The current protocols include 30-minute sessions every week for at least 12 weeks and then monthly follow-ups. That's not always easy to do. A recent development was this completely implanted battery-powered unit that there is a specific template and instruments to implant it in the tibial region. And what offers is a 30-minute stimulation every 2 days for the first 12 weeks, and then once every 15 days. And there has been a reduction in the incontinence emissions of 71%, and patients with more than 50% improvement were 69% at 3 and 6 months, and also there was more than 20% of patients that went completely dry after this procedure. Another idea would be to use an injectable or implantable lead and then power it externally with another device like a bracelet that you could wear around the ankle. This is the example of the Blue Wind Renova system that is under investigation and shows good results so far. There has been other attempts for implantable tibial neuromodulation, but they're not currently marketed for urinary problems. One other idea was to use vaginal neuromodulation. This is a kind of pessary that offers electrical stimulation, and studies to evaluate it are underway. Another idea was to use cavernosal neuromodulations for patients that underwent open radical prostatectomy, and they were implanted with the electrodes at the same time. This is a feasibility trial, and what they found out was they had 75% visual physiological response. That means penis penile enlargement. It is not a clinical trial. Nevertheless, two of the authors have applied for patents in this, for this device. And neuromodulation sometimes means stimulation, some other times means ablation. This is an example of dorsal penile RF ablation for premature ejaculation. And RF ablation is under investigation as well for this device, the Amphora Medical Silencer system, that uses a cystoscopic device to produce denervation under the trigone to treat bladder overactivity. And what I have shown you so far is a glimpse of the near future. Let's go to the far future. A very promising technology is optogenetics. Optogenetics, what we use is we genetically engineer cells to express an opsin. An opsin is a membrane protein that can have different functions. And when stimulated under a specific light, it can activate or deactivate the cells. And what they have done in this experiment is that a sensor was implanted surgically around the bladder of mice. And when there were abnormal contractions, a signal was sent to the base station. There's a control unit there. The sensory nerves of the bladder have been genetically modified by using a herpes simplex virus vector to express an opsin. So when the base station activated the LED lights, there was a reaction of the sensory nerves to reduce the bladder contractions. So all this may sound like science fiction, but sorry. Εδώ λείπουν δύο διαφάνειες. Okay. So all this may sound like science fiction, but, and of course it will be difficult to apply in human beings because this procedure is quite invasive and the neural pathways of the human bladder are different and the thickness of the bladder wall is different, so it would not be easily, light would not be easily transmitted, but human trials with optogenetics are currently underway, especially for eye conditions, so that might not be a very far future. And in conclusion, the neuromodulation is a thing of the future. It will continue to grow, but we know for experience that so far many medical devices in the field of urology have come and failed the test of time, so only time will show us what will happen from now on. For the time being, especially for Greece, the InterStim is the only thing available, so that's the take-home message, I think. Thank you very much for your attention.